Welcome back, everyone, to part 31 of our IPDRG Masterclass. I'm Harshal, your lead instructor, and today we're decoding one of the most intricate and honestly fascinating areas in medical coding, ICD-10 PCS cardiovascular system procedures. We've got a ton of critical guidelines to unpack, so grab your notebooks. We're going to master everything from bypasses right down to coronary interventions.
But before we dive into the deep end, just a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is what keeps this masterclass series free and accessible to focused learners everywhere.
All right, let's do a super quick recap. Back in part 30, we conquered obstetrics procedures and section 1. We looked really closely at products of conception and extraction rules, right? And that lesson required us to be highly specific about the objective of the procedure and the exact anatomical site. Well, that mindset is the absolute perfect foundation for today's complex cardiovascular rules, because precision in every single character is quite literally vital here.
Okay, here's our game plan for today. We're going to crack the KBG code, decode PTCA and PCI, tackle pacemakers, AICDs, and valves, and then wrap it all up with a solid coding summary. Let's get right into it.
Section 1. Cracking the KBG code, focusing on root operations and those all-important key rules. Now, cardiovascular coding is notoriously tricky. It demands strict attention to the rules, especially with open heart surgery. Because honestly, a single misunderstood character can completely alter your DRG assignment. Take a KBG, or coronary artery bypass grafting. We use the root operation bypass. In the PCS manual, bypass is always coded with character 1. The fundamental objective here is altering the route of blood flow past a coronary artery obstruction. You are literally building a detour for the blood to travel through. Let's map this out using the standard 7-character PCS structure for a CABG. If we're using an open approach with an autologous artery graft for a single site, our code comes out to 021003Z. Look at how each character tells a very specific part of the story. Character 3 is our root operation, 1 for bypass. Character 5 is our approach, 3 for open. Once you see it laid out like this, it's actually a highly logical system.
But here is the crucial point where so many coders trip up. According to guideline B3.6b, the body part, that's character 4, identifies the number of coronary artery sites bypassed. Think 1, 2, or 3 sites. It absolutely does not identify the anatomical name of the specific arteries. Meanwhile, character 7, the qualifier, identifies the origin of the bypass, like the aorta or the internal mammary artery. Basically, you're mapping the route from the qualifier to the number of sites.
Building on that logic, if multiple sites are bypassed using different devices or qualifiers, let's say one from the internal mammary artery and one using an autologous saphenous vein, you absolutely must assign a separate procedure code for each. Plus, guideline B6.4 is super clear here. When a saphenous vein graft is harvested from the patient's leg to be used in the heart, you have to assign an additional, separate code for the excision of that vein. You're doing surgical work on a completely different body part, so you've got to capture it. Moving right along to Section 2, decoding PTCA and PCI, also known as percutaneous coronary interventions. So, transitioning away from those massive open bypass surgeries to minimally invasive procedures, we look at PTCA, or percutaneous transluminal coronary angioplasty. This uses a completely different root operation, dilation, which is coded as character 7. Why dilation? Well, because the surgical objective isn't to reroute the blood this time. Instead, it's expanding an orifice or the lumen of a tubular body part. We're literally stretching the existing artery open, usually with a balloon.
Now, often during this dilation, a stent is left behind to keep that artery propped open. This is where the device character, character 6, changes based on what's in your operative report. You've got to carefully verify, was it a drug-eluting stent, a regular bare metal stent, or maybe no device at all? A drug-eluting device gets character 4, while a non-drug-eluting device gets D. The details matter here.
And here's another major pitfall to watch out for. You have to carefully distinguish between the number of arterial sites dilated, which, remember, is captured in character 4, versus the actual number and type of stents placed, which is captured in character 6. For instance, a doctor might dilate 2 separate arteries, but only end up placing 1 stent. You've got to capture both of those data points accurately across those specific characters.
All right, Section 3, pacemakers, AICDs, and valves.
Let's look at insertion, replacement, and supplement.
This brings us to a few new root operations specifically for implantable devices. Let's take the AICD, or Automated Implantable Cardioverter Defibrillator. Devices like the AICD and biventricular pacemakers are coded using the root operation insertion, which is character H, and the reason for this is that they're non-biological appliances put in to monitor, assist, or perform physiological functions. But, and this is the key distinction, they do not physically take the place of a body part.
If you think about the anatomy for a second, you can clearly picture the pacemaker generator resting in the tissue near the collarbone, while the leads snake down through the vessels directly into the chambers of the heart. That distinct physical separation perfectly explains why coding these devices is always a two-step process.
Because of that anatomy, you've got to decouple these two parts when you code. First, you code the placement of the pacemaker generator to the subcutaneous tissue and fascia. Then you code the placement of the leads completely separately to the specific heart chamber, like the right ventricle. Never ever try to bundle them into one code. The PCS system absolutely requires you to map exactly where each piece of hardware lives in the body.
Heart valves, on the other hand, have their own strict logic. You've got to distinguish between replacement, that's character R, which physically takes the place of the existing valve, like in a total aortic valve replacement. Contrast that with supplement, character U, which just physically reinforces or augments the existing valve, kind of like a mitral valve annuloplasty using a ring. Oh, and remember, if they just go in and use a balloon to open a stiff valve without leaving a device behind, that is simply dilation, character 7. Finally, Section 4. Let's do a quick cardiovascular coding summary with our key takeaways.
We've covered some truly massive concepts today, so please keep these golden rules handy. First, count your CABG sites for character 4 and map your origin in character 7. Second, if you harvest a vein, you code it separately. Third, check those stent types meticulously for your PTCAs. Fourth, always split your pacemaker codes between the pocket and the leads. And lastly, precisely identify the root operation for valves by asking yourself one simple question. Are we replacing, reinforcing, or just stretching it open? What an incredible deep dive. We covered so much ground today, but following this structured logic is exactly what will ensure your codes are perfectly accurate. Now, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. As you review your charts this week, ask yourself, are you accidentally leaving money on the table by bundling codes that CPCS explicitly demands you split? Think about that. Keep studying those guidelines, and I will see you in Part 32, where we are going to conquer the musculoskeletal system and joint arthroplasty. Until next time,